sure not only in Africa, but even when we go outside and we talk to development partners, they use your countries as examples. You know, you moved a long way. You've got over 60% coverage. Share with us the key challenges as a CEO you're going to face, and what are you planning to do about it?
Sitting in the morning section, and we're grappling with the definition of universal health coverage and the approach to it. We heard about all the difficulties various countries in Africa have expressed. The Ghana experience has been touted as a good one for many years, but it didn't come as just one single decision suddenly that we're going to do this. We had to walk through a path, and I must say that this path happened years ago when we gained our independence, and the then president championed the path for universal health coverage then in 1957, and it was touted as a socialist policy and shunned by people in the private sector. The government could not continue that policy because it was solely funded by the states, and the state could not provide healthcare for all its citizens as the population grew and the resources started dwindling. So after 10 years, a decision was taken now to try and let the citizens pay a token amount when you visit the hospital, what we call the out-of-pocket payment when you visit a facility. But that was so little because the people could not afford anything bigger than the government proposed, that it was insignificant in terms of maintenance of the facilities that the government had rolled out across the country. We were back to square one with a notorious policy we called cash and carry. Cash and carry purely meant that you go to the facility, you are informed that your care will cost you maybe $500, and then you put $500 down and you are shown access to care. If you don't have $500, you are shown the exit door. Healthcare had become a political football. That was the main thing on the menu for the political campaign in 2000 in Ghana. And then one of the political parties championed the fact that when they win or when they are given the mandate, they will implement universal healthcare and abolish the notorious cash and carry. So just saying that they will abolish cash and carry was a big political slogan. By their word, by 2003, an act had already been passed in Parliament establishing universal healthcare and stipulating certain categories of people in the country who are not allowed to pay anything when they visit a health facility. The advantage Ghana had is because ours started as a universal healthcare at independence, almost about 90% of the facilities, health facilities in the country, by the time universal healthcare was introduced, was all either government owned or owned by the mission hospitals. So all these facilities, if you are under 18 years, or you are over 70 years, or you're a pregnant woman, or you are a category they define as an indigent, which is you're unemployed or your income is so low that you cannot afford to pay what we call a premium. A premium was like $1 a year or $5 a year, and then the processing fee $1 a year. So total, if you are working, then you pay probably about $6 for a whole year. If you are described or defined as an indigent, then you do not pay the $6 a year. That is how it was started. A lot of people thought the money was so small, it will not be able to care for anything at all, because the government set aside 2.5% of our VAT. And then those who were employed and had in the formal sector had to pay 2.5% of their earnings of their social security towards that health fund. So that health fund is what Mr. Thakker talked about, that was started in 2004. By that time, there was enough money based on this financial model to look after most Ghanaians who registered with the National Health Insurance Scheme. By 2009-2010, as usual, because it was more or less 95% free, because 95% of the funding was from the VAT and the SNE contribution. Only about 3% was coming from the public in terms of this $6 a year, and about 2% from donor funding. So by 2010, the financial model collapsed, and all the reserves the National Health Insurance Scheme had was non-existent, and the old service providers in private sector, government sector, the quasi-government sector, millions of dollars. So the natural consequence of when the financing model fails is that the service providers now decided to take unauthorized fees from the patients. So the system broke down. Healthcare, because of almost collapsing in terms of National Health Insurance Scheme not paying their service providers, became a huge political football again. Now, this is where Ghana is now. People have tasted the need or the benefits of the National Health Insurance Scheme. People want it and they demand it, and it's always on the radios, it's always being discussed. You're not allowed to run away from it because it's always on the menu. And because of that, we're shepherding a way now forward. What do we do with the financing model? What do we do with the inefficiencies? Because now a lot more people want to enroll on the National Health Insurance. So we're looking at avenues to bring the private sector in, and the discussion is not been easy. Instead of going for 2.5% VAT, that percentage has been decoupled from the VAT. Now we have 2.5% health insurance levy, which is detached completely from the VAT, so that if there's any increment at all on that levy, it is not defined as maybe increment in VAT, which the private sector or the business community frown upon. They frown upon increase in VAT. Everybody don't want an increment in VAT.
Right.
But that has been decoupled now. We're looking at the revenue streams.
Right.
We're looking at other sources of revenue that tax on health tax, like on tobacco, alcohol, and all those, to make sure that if we say the scheme is accessible, the insurance is accessible, then people can just sit in the comfort of their homes using their mobile phones to join the scheme or renew their membership. We're trying to use technology to reduce the difficulties in trying to enroll with the National Health Insurance. Most of the millions of people we have on our system are the downtrodden and those who fall sick frequently, who go through every difficulty to enroll. The second challenge is the financing model that I was talking about, that we're dealing with, and they're reducing inefficiencies in the system. In terms of how you process your claims, make sure that you audit the claims properly and all that. Make sure that every penny that is given for the health care of the people are accounted for.